Did you have a question all the way in the back?
I wondered, what about doing periodic laparoscopies instead of CT scans, and also what about MRIs instead of CT scans?
Yeah, the periodic laparoscopies I don't recommend unless there's a reason to do that. I mean, it's something questionable. Yes, any procedure has some potential side effects. Yeah, it could be significant, so especially after any major operations. Unless you have something specific that is not clear, laparoscopy in a routine is not really a good idea. MRIs and CAT scan, they're all imaging modalities, and depending on the expertise of the people reading those, you're going to get similar results. MRIs are more difficult to read by most of us. You need to have a lot more experience to read a good MRI. And in the abdomen, both are not that good unless you have big disease. For a small tumor, nothing is helpful.
But if you have somebody that's good, you think they can read an MRI can give you as much information as a CT if you have a good radiologist,
Yeah,
or
I
not?
will agree with that.
Yeah, like it was one of the questions we actually had was, in particular, whether you had any opinions on sort of the Barone MRI method for follow-up as opposed to CT, especially given the current literature around exposure to the radiation of a CT scan.
Yeah, I actually reviewed that with our radiologists, particularly who are interested in MRI, and they think it's very reasonable. But again, you really have to have a tumor of a certain size in order to say an MRI is only so good. It's not going to pick up something that's 2 millimeters. But I think one of the things that Dr. Barone is really trying to emphasize with the MRI and the way they use it in their delayed gadolinium enhanced images is that they can, he suggests that they can really tell a difference between mucin and the cellularity of the tumor, which could really potentially be helpful, I think, for the surgeon who's planning the surgery, because a lot of times you'll look at the CT scan and you'll say, oh yeah, this is just going to be a lot of mucin, and it should just come right out, and you're kind of geared up for that, and then you get in there and you actually find out, well, it's a little bit more adherent or a little thicker than you thought. It's not chip shot, but it's not as easy as you thought it was going to be, and the day gets longer and it gets harder. So I think that is a potential benefit of the MRI, as well as the lack of radiation. And with regards to the question about laparoscopy, there are a number of patients who fall into this nebulous zone of, there was a question of maybe a little bit of mucin outside of the appendix. It was a cystadenoma or a mucocele. What do we do? We're in this watchful waiting scenario. CT scans, again, are only so reliable. It's a person who wants to treat this as early as possible. And in those settings, if a person's having a negative CT scans, I will actually offer diagnostic laparoscopy at about a year out to make sure that what we're seeing on the CT scan is reflective of what's going on, and see if there is an opportunity to identify a small amount of mucin if it's present there that you wouldn't see on the CT scan. But I also tell people at the same time, and I don't know if you guys have ever seen this, but I've never seen somebody go from having nothing on a CT scan to a point where there's nothing. Once they're in the system and you're following them carefully with the DPAM, with the true PMP, to go from nothing to, okay, we missed an opportunity to cure this person, especially if you're following them every 4 to 6 months with a CT scan. So I really tailor that laparoscopy recommendation to each individual person, where their level of comfort is, how much do they want to know, how early do they want to know it. And if they say, I'm okay with just following the CT scan, I don't worry that we're going to miss an opportunity to treat for cure in those patients.
No, I agree. I think you'll still have a very early patient if you see a wisp of something on the CT scan, and those are the patients that will do very well. I don't think you'll lose an opportunity. And you may. If you're going to do the laparoscopy and it's going to be negative, you're probably going to end up following it anyway.
Right, you're going to follow it.
So,
but for some peace of mind, and then there's a group of young women who perhaps are interested in trying to have a family and start a family, and that's a group that, if you just really want to confirm that the CT is negative, I think that's helpful for them if they're at that point where they're trying to. I'm just thinking of individual circumstances where I've done it for people. So.
After HIPEC, though, you don't want to do recurrent laparoscopies. See whether the tumor is coming back, and that's not a good idea. But I agree with the other. The other thing that to mention about quality of life, and is the issue of reproductive, surgery. A lot of young people are affected, and the question is, should you, freeze semen? should you, save some of the ovary? Is this okay for future? No, that's something that if you have your family and you are looking into, family, that is something that probably should be talk about it actually as well. Because any of these chemotherapies, both systemic or intraperitoneal, can actually, compromise your ability to have children in the future.